Thank you, Ajay, and to the Society for this very kind invitation and this kind introduction. Thank you, SP, as well. My greatest accomplishment is being from India and born in India and then going to Armed Forces Medical College. And so, and I'm very grateful to one of my professors here, Professor A.C. Anand, because he used to be my professor in medicine. And I think you wouldn't believe that I would have private tutorials with him on things like hyponatremia and management of hepatic encephalopathy. And I didn't know at that time that I'll be becoming a hepatologist and be standing here in front of Dr. Anand. So thank you for having me here. These are my disclosures. And today we will discuss mainly two areas: to understand non-invasive risk stratification of patients with suspected metabolic dysfunction associated steatotic liver disease, and to understand predictors of treatment response. And we'll focus on what's new, particularly in the last 1 to 2 years. Globally, MASLD is present in 1 in 4 individuals. There's a clear ethnic predisposition where Asian Indians have higher predilection, followed by Hispanic, then Caucasian, and then African American are protected. Risk factors include metabolic syndrome. There are at least 3 genotypes that increase the risk for MASLD. They include PNPLA3, TM6SF2, MBOAT7. There's also a protective genotype, which is HSD17B13. Today, we're not discussing treatments related to precision medicine, but within the next few months, you will see new therapies that are targeting these genotypes, where we will silence one of these genes to see effect in patients with steatohepatitis. And that work is already ongoing. MASLD is diagnosed either on biopsy or imaging evidence of hepatic steatosis, where at least 5% of hepatocytes are infiltrated with fat, with at least 1 metabolic risk factor in individuals who consume little or no alcohol without any other cause for liver disease or hepatic steatosis. Why is it here? Well, it's really important that we are on the same page as we start discussing a disease. If you look at many publications, when you're trying to look for a definition of disease, you will not find. So it's really important to crystallize that in 3 or 4 statements if you can, because it helps you frame it to the people you're discussing it with. If you were to diagnose MASLD, the first question comes, does my patient have hepatic steatosis? And how do you assess that? And what are the most important ways of differentiating whether somebody doesn't have it or somebody has it? Well, liver biopsy assessment has been the clinical standard, but of course that's subjective and qualitative. And this is not something that we routinely do across the 1 billion people who may have this problem. Conventional ultrasound is routinely utilized, but it lacks sensitivity, which means that if patient has a little bit of fat in their liver, it may be misread as normal. And it also could be misread as abnormal in the setting of other problems in the liver, such as fibrosis or iron overload. CT scan is not favored because of ionizing radiation, and it's inaccurate many times, but also lacks sensitivity and specificity. On FibroScan machine, there's a parameter called control attenuation parameter that can be used to differentiate fatty liver from not. It's not helpful for quantification for liver fat, but could be used. And what we've done is corresponded 288 decibel per minute on CAB with MRI PDFF of 5% or higher. And again, that benchmarking is important. And you'll see across the spectrum of our research, what we try to do is develop a gold standard first and benchmark it to that gold standard. Many times, the type of research or clinical practice we are doing, the gold standard is shaky. And that's where the problem comes when we are trying to associate or develop new markers because the gold standard itself is shaky. So you want to really establish that where you have fixed association that is strong and will not change with time. The gold standard to quantify fat or hepatic triglyceride content is MR spectroscopy. This modality requires specialized software, specialized coils on your MR scanner, and also physicists. So it's not feasible in a routine MRI scanner down the road here in Kochi. So what we did was we worked with a group of physicists and UCSD, but in parallel there was another project going on in Wisconsin, and we collaborated together, and we came up with two different modalities to quantify liver fat. At UCSD, it was magnitude-based MRI PDFF, which is here to the right, and in Wisconsin was complex MRI PDFF. And you can see this is the same patient. Both modalities give you the same 29% fat in the liver, patient of mine who had these done at the same time. The value of this test is it gives you an estimation of liver fat without requiring the coils, without requiring additional hardware, but using the MR scanner that you have, you could predict how much liver fat a patient may have, and it's quantitative, and it's not affected by age, sex, BMI, etiology of liver disease, inflammation, or iron overload, which used to be a problem with previous modalities. Now, this is the effective gold standard that has replaced other evaluation for liver fat. Once this was established, we wanted to change the paradigm. The traditional paradigm for liver disease assessment remains that you do a liver biopsy in a patient, and then you see where the patient is today, and then you follow the patient long term to see an improvement in the liver histologic variables. We thought that if we could replace the liver biopsy assessment with a quantitative and also an objective measure of assessing liver disease. So if we are looking at steatosis, inflammation, ballooning, and fibrosis, could we replace each of these by key variables that would be better or more reflective of the changes that are happening in our patient? So the paradigm we developed was to develop new biomarkers such as PDFF, multi-scan, 2D, and 3D MR elastography, along with serum-based biomarkers to improve efficiency of diagnosis and also assessing treatment response. One of the biggest problems in the field was that you would use a drug and you're not sure if you will see a response in 6 months or 1 year and how many patients you would need. So you need efficiency to quickly screen different molecules to find an efficient way of which drugs are working. So this is almost 10 years ago where we established liver fat maps before and after treatment just in 6 months. And what we found was that liver fat was heterogeneous in our patients. And so you had to look at the same spot before and after treatment. And this co-localization was really important. So we would co-localize in 9 segments of the liver before and after treatment and follow a patient if they're improving or getting worse. Similarly, we developed co-localization slices for MR elastography to quantify changes in hepatic fibrosis before and after treatment. This is on 2D MRE and this is on 3D MRE. The first 4 trials were done at UCSD utilizing both of these modalities that set the standard. And as Ajay mentioned, now more than 100 trials worldwide use MRI PDFF to assess treatment response, and we have clinical predictors how we can say patient is responding or not. But if you look at population risk assessment that you may be doing in your clinic, what tools can you utilize? For that, typically now, we have come to a consensus across EASL, ASLD, Apostle, and several organizations where you could use a FIB4 assessment, which includes an age, ALT, AST, and platelet. What it does is it gives us a likelihood of whether a patient has advanced fibrosis or not, and typically has a high negative predictive value. A score below 1.3 rules out advanced fibrosis at the level of population, and a score of 2.67 or higher is associated with higher risk of advanced fibrosis. And there are some patients who are intermediate in between. Similarly, in Europe, and now used also in United States, is a serum-based fibrosis marker called ELF, Enhanced Liver Fibrosis Panel, that includes 3 biomarkers, hyaluronic acid, P3NP, and TIMP1, that provide you some estimate of fibrosis in the setting of liver disease. An ELF score of 9.8 or higher is associated with advanced fibrosis. And this is also utilized in our clinical practice now. So recently, a group of us worked together to develop the ASLD 2023 NAFLD practice guidance. In this guidance, in a simplified manner, what we said, if a patient has metabolic risk factor, suspected MASLD, you start with first assessment with a FIB-4. And if the FIB-4 is 1.3 or higher, then you would want to do a second test. And that second test could be a FibroScan-based liver stiffness measurement, or you could use an ELF test. But you can use other modalities as well, although data is not very good on shear wave elastography, but you can use that. Data is very strong for MR elastography, but it may not be accessible at many places. But I know in India, in many institutions, MR elastography is being utilized. So for example, in Japan and South Korea, MR elastography is more commonly used, particularly in Japan and FibroScan. So depending on the clinical access that you have, you can use many of these modalities to risk stratify a patient. I think most important thing is to identify that these tests are not extremely accurate. So you may lack that precision that's needed, and that's why you want to have an effective gold standard, and that's what we are approaching in many of our research or the publications that we produce. Once you've identified patient has risk for advanced fibrosis, there'll be typically a patient with a FIB-4 above 1.3 and a liver stiffness on FibroScan above 12 kilopascal. Another question that comes up is who needs to be treated who has MASLD? And these are patients who have NASH with stage 2 fibrosis or higher, with NASH being qualified as presence of steatosis, ballooning, and lobular inflammation. If you meet all of these criteria and have stage 2 fibrosis, that's the patient who's at increased risk for dying from liver disease. And so how can we diagnose that without needing a liver biopsy? So clearly we didn't have a single test, so we started pooling many of the biomarkers together to look at an imaging plus a serum-based test. And here are 3 examples for you that are now listed in the clinical practice guidance that could be utilized. So FAST is one, which is CAP, fat quantification liver stiffness by VCT and serum AST. You can combine it, it gives you some idea. Typically, a FAST of 0.67 or higher is associated with presence of at-risk MASH, which is stage 2 fibrosis with MASH. MAST is a combination with MRI-PDFF, MR elastography, and AST. And MEFIB is a simpler modality where you do a FIB-4 first, FIB-4 of 1.6 or higher, and then you do the MR elastography. If it is 3.3 kilopascal or higher, you have more than 90% positive predictive value that this patient has stage 2 fibrosis. So you could consider pharmacologic therapy if you had one. This is straight from the ASLD practice guidance where you could use any of these tests and the cut points are listed so they can be useful in your practice. There's another test called CT1, which is available from Perspectum that can also tell you whether a patient has inflammation. Typically, a score above 875 millisecond is associated with NASH stage 2 fibrosis. So that can also be utilized. So now we've diagnosed that a patient has at-risk NASH with some certainty without needing a liver biopsy. How do we really assess if the patient is improving or getting worse? Before we do that, I'm showing you some data where we did head-to-head comparison between these 3 diagnostic tests for at-risk MASH and showed that MEFIB was better than MAST or FAST, both in the United States and in a validation cohort in Japan. These type of comparative efficacy and effectiveness studies are important as you're thinking about using these biomarkers in your clinical practice. So to simplify, hierarchy of NID for fibrosis assessment, say MR elastography, provides you the greatest accuracy, followed by CT1, followed by FibroScan, assess liver stiffness measurement, and then a FIB-4. What about new data on liver stiffness? So I'll frame this. This data are based upon 4 large randomized controlled trials where the drug did not work, but we had data on outcomes long term. So the question is, if you saw a patient with bridging fibrosis today, you saw 100 patients, how many of those would progress to cirrhosis over the next 2 to 3 years? And can you predict that? And the answer is yes. About 20 to 25% may progress over the next 2 to 3 years. And it's based upon their baseline liver stiffness. Say 16.6 kilopascal or higher, written here, is associated with higher risk of disease progression. And what is disease progression? is 5 kilopascal plus a 20% increase. So you not only want to have a percentage increase, but also on top of it 5 kilopascal. So that's helpful. What about hepatic decompensation if you were cirrhotic? You again had 100 cirrhotics with NASH. How many of those are going to progress and decompensate? Because if you know that, it'll be important for you to see how often you should see them. And what is that cut point? So the hepatic decompensation is NASH. It's not happening at liver stiffness of 20 kilopascal. It happens at 31 kilopascal or higher. And so you look at the Baveno criteria, it's really not based upon data in patients with MASLD, but it's a good approximation, 20 kilopascal, 25 kilopascal. But the real decompensation based upon these data happens at 31 kilopascal or higher. And those are the patients where you will start seeing increased risk of liver-related events. Below 30 kilopascal, the risk is pretty low, as you can see over here. So as you follow your patients, these data could be helpful. So if you were to remember something, in a cirrhotic, 30 kilopascal or higher is where you start seeing decompensation. In a patient with bridging fibrosis, 16.6, or simplified by 15 kilopascal or higher. And the rule is at least 5 kilopascal increase plus a 20%. This is new data from Vincent Wong and colleagues combining data from Europe as well as Asia, where they looked at many patients and looked at trajectories based upon liver stiffness assessment in a heterogeneous group of patients with MASLD, a big cohort. And what they found was that you could use scores such as Agile to predict whether a patient is worsening or improving. Although you could use Agile, but the most important factor within that is liver stiffness again. So I like to again simplify to what we can clinically use quickly in our clinical practice, because I know many of you see 40 to 50 patients in a day. And so again, liver stiffness assessment is the most prognostic factor within any of these scores, so you can use that on FibroScan. So based upon this study, a 30% increase or a 30% decrease is associated with either liver disease progression or regression. So you could use that criteria too. This is data from 6 different cohorts, international, where we pulled data on MR elastography. And what we showed that if you had on MR elastography 5 kilopascal, that's cirrhosis, and an increased risk for liver disease progression. If you had 8 kilopascal on MR elastography, you have pretty high risk of hepatic decompensation and dying from liver disease over the next 2 years. Here we show also a prognostic value of MEFIB positive and MEFIB negative. The patient met the MEFIB criteria, that's why you want to treat them, because they're high risk for decompensation over the next 7 years. MEFIB negative patients can wait. This is again new data on liver stiffness in cirrhotics, where we found that there's a high variability for FibroScan in cirrhotics, about 38% compared to 20% on MR elastography. That's why if you're seeing your patient, you don't want to be repeating FibroScan every 3 months. That's not going to be helpful. It'll cause more confusion. Typically, you want to wait at least 1 year or longer before you repeat your FibroScan, so you can really see and also contextualize with what's happening with their other liver tests. What about predicting treatment response? So the MRI PDFF of 30% relative reduction over 3, 6, or 1 year is associated with 5 times higher odds of NASH resolution. This has been shown now in multiple clinical trials now. Actually, every single drug that is now in phase 3 meets this criteria. These are some of the other biomarkers of histologic response, such as serum ALT, which we showed many years ago, that at least a 17-unit decline is associated with histologic improvement. PDFF decline of 30%. You see a 50%, that's a super response, even higher likelihood of histologic response on NASH resolution. On multi-scan, 85 milliseconds. On FAST, about 0.2 score decline in FAST is associated with NASH resolution. On MR elastography, about 20% reduction is associated with improvement in disease. We also combined 3 modalities such as MRI PDFF, serum ALT, and a baseline AST that gave us a pretty high likelihood of MASH resolution index approaching 80% accuracy. This is based upon data from UCSD. And then last year we published a paper on pegozafermin, New England Journal of Medicine. This is data looking into pegozafermin responses, and we have similar diagnostic accuracy. So now we have tests that can easily predict NASH resolution without needing a liver biopsy. This is a recent paper in tirzepatide, which we will discuss tomorrow for treatment of NASH. And many of these parameters that I mentioned have been shown to be associated with histologic response. So we showed that tirzepatide leads to improvement in both NASH here and also in fibrosis compared to placebo. And what we find that in this table that there's a dose-dependent effect on liver fat improvement. We also see improvements in liver stiffness on FibroScan, NIS4, which is a serum-based biomarker for disease response, and ProC3, which is a fibrosis response biomarker, similar to ELF. In summary, fibrosis assessment for risk stratification has taken the center stage in clinical practice using FIB4 followed by LSM. LSM is prognostic and routinely used. We can now detect at-risk MASH using many of these clinical prediction rules. PDFF response of 30% is associated with NASH resolution, and MASH resolution index could also be utilized. Advances in serum biomarkers and point-of-care imaging will disrupt future clinical trials and clinical practice and will form the backbone of future registrational trials in MASH and fibrosis. With that, thank you. Happy to take any questions.